This is one patient who had an unexplained bleed in the anterior chamber and presented to us in OPD. Now, this was the patient's eye at the time of presentation, and we can appreciate that there is a liquid blood and a clotted blood in the anterior chamber. And we can see that the inferior level blood, which is bright red in color, is the liquefied blood which is present in the anterior chamber, and above that in the temporal two-third we can see a clot. The pupil has been dilated, so we can see part of the pupil. Otherwise, this patient's vision was grossly compromised to finger counting close to face, and patient's pressure was nearly normal, which was measured on rebound tonometer and came out to be 16 millimeters of mercury. And this patient had no contributory illness or disease which could explain this happening of spontaneous bleed in the anterior chamber. Patient was not on any anticoagulants as well. So it was decided to remove this blood clot, fearing that this might cause elevation in intraocular pressure in coming days, and as well as to relieve him of the diminution of vision. So once the anterior chamber entry has been created, intracameral lignocaine has been introduced, which washes away the part of the bleed which is liquefied and collected in the anterior chamber. Usually the anterior chamber bleeds don't get clotted, the reason being that once the blood is mixed with the aqueous, the clotting factors are diluted to the extent that they cannot polymerize and cause a clot. However, as we can see in this case, whenever the bleed is in larger quantity, the dilution effect of the aqueous is nullified and the blood can clot. So here an entry has been made which is not exactly 2.8 millimeters, that which was the size of the keratome, but instead it is just an opening which will allow passage of a Simcoe cannula with no leakage, and the clot which is there cannot be pulled out using a rhexis forceps because the clot is cheesy and it simply cheese wires when it's held with a forceps. Rather, the better strategy is to hold it using vacuum, using either a irrigation aspiration handpiece. Here we are using a Simcoe cannula which is far more safer and well controlled, being a unmechanized tool. So we are using the active aspiration being created by a syringe 5 ml, and we are holding the clot and pulling it out, and it is apparent that it is coming out piecemeal just because the opening is small. But the advantage which this small opening provides is the chamber is well maintained, and which is so very important to prevent any occurrence of cataract in the crystalline lens, also to protect the endothelium. So once we have nearly whole of the clot removed, we will see once the clot has been cleaned out, the glow appears, and it is not uncommon for these eyes to have some abnormality. So it is very important to counsel these patients for possibility of a recurrent bleed which may be there because of some abnormality, maybe iris vascularization may be there, but because there was no contributory illness, so we had kept our fingers crossed, and although the prognosis and possibility of such an event that there may be a rebleed causing further diminution of vision can occur in spite of clearance of this blood. So it's a repeated procedure which needs lot of amount of patience. Otherwise, if the wound would have been made larger, we could have removed in single go, but then there would have been a possibility of causing collapse of the chamber and some damage to the tissues. Now anterior chamber has been cleaned and there is some amount of iris prolapse in the wound which will be reposited later on. There is some amount of cellular level of contamination of the aqueous with the blood which will need either wash or flushing can be done. Once this clot has been removed, we are injecting BSS to form the anterior chamber and also to flush out any remaining blood which may be trapped behind the iris. So it's mandatory that good amount of flushing is done so that none of the bleed or clot is retained inside. Once you inflate the anterior chamber, the pupil dilates further and the case has been finished. pressure is well maintained, the wound is sealed. This is the patient's picture the next day when the anterior chamber was absolutely clean, there was no rebleed, and patient vision improved to 6 by 9 unaided. This is another photograph which has been taken using a mobile phone, and I would like my audience to comment which of the photograph appears better. Thank you.